advocacy organization. Our mission is to achieve high-quality, accessible, affordable health care for all Ohioans. We have offices, our main office is in Columbus, but we also have an office in Cincinnati and Cleveland. And we work on issues of access to health care, health system transformation, and population health. We work across the age spectrum, and the logos of some of our campaigns and projects are at the bottom of this slide. Next. So the Somebody Finally Asked Me campaign developed within the last 18 months. It seeks to spread the use of the screening, brief intervention, and referral to treatment strategy in youth settings throughout Ohio, particularly in schools. The project is funded by the Conrad N. Hilton Foundation, and we receive guidance and technical support from Community Catalyst in Boston. The project is called True Talk: Power of Prevention. And we operate with a leadership team, an Ohio-based leadership team that includes the Children's Defense Fund Ohio, Prevention First, which some of you are familiar with, especially if you're in the greater Cincinnati area, the Collegiate Recovery Community, which is headed up by Sarah Nerad at Ohio State University, Interact for Health, which is a foundation that has funded a lot of SBIRT work in Southwest Ohio, Ohio Citizen Advocates for Addiction Recovery, UHCAN Ohio, the Urban Minority Alcoholism and Drug Abuse Outreach Program, which is usually referred to as UMADOP. There are 11 in Ohio, and these are the Cincinnati and Columbus programs that are part of our team. And finally, Voices for Ohio's Children. So I want to just say that SBIRT is being done in other places in the United States. Baltimore, Maryland is one of them. It's in either 6 or 7 high schools in Baltimore. They chose to go into the high schools where the drug problems, based on census data, were considered to be the most significant. I named Gloucester, Massachusetts, but actually it's in a number of communities in Massachusetts. In fact, Massachusetts has actually screened over 3,000 students in their program. It is also, and also just I wanted to mention about Massachusetts, they have a nice tool for data collection. We can make that available to you later. And in the statistics that they've maintained, 92% of the students that they screened screened negative, and 7% required some kind of follow-up negotiated intervention of some type. I think 3% opted out, which means their parents basically opted them out of the practice. SBIRT is also being done in New Hampshire. It's been done for quite a while in New Mexico, and it has been done in New York, both in New York City, Long Island, and upstate New York, the Rochester area and some surrounding areas. Primarily there, it's been done in school-based health centers, and they have done data collection and looked at a comparison of the downstate and the upstate projects. In Ohio, it's being done in Lima, Ohio, in a school-based health center run by the Federally Qualified Health Center in that area. And then, of course, in Norwood, Ohio, which you'll hear about later. In Wisconsin, it has been done in several places. And in those places, they've screened the 9th and 10th grade students in 3 local high schools. And I'd like to just close this part by presenting a comment that one of their students made. I think that it was really nice to talk about, and I'm glad that she talked to me about this stuff. And she is talking with people around the school. This is good and healthy to talk about this subject with people. And that, of course, is the thing that motivates most of us who are trying to do SBIRT in schools, because there are those anecdotal stories and comments which tell us that we're on the right track. So what I would like to do now is turn this over to Deb Robison and Kathy Strasser in Norwood to talk about how they have implemented SBIRT in Norwood City Schools.
Well, good afternoon, everyone. We just wanted to give you kind of a quick overview of how we got started with our program. As we were preparing for this, Kathy and I realized, well, we knew this all along, but SBIRT in and of itself is really pretty simple, but all of the things that go into it on the front end are the things that make it a little more challenging and a little more difficult. So one of the first things we did was we had to assemble a team, a planning team, and our planning team consisted of a representative of our Norwood Health Department, Kathy, who was a school nurse, myself with Family and Student Services. We had representatives from Talbert House, which is our local mental health and substance abuse agency, Prevention First, who provided some technical assistance, and Interact for Health, who was our funding partner. And that was the team that we put together to start to think about how we would do this. And part of what we realized in our planning process was that we had to do some work to help identify students before they got into trouble. We know that about 30% of our students in the high school were reporting some kind of use of alcohol within the past 30 days on our student drug use survey. And so we also know that kids are, they get in trouble at school, and because it's a zero tolerance kind of situation, they are out the door. So it's not a situation where if a student is identified, we get a second chance to work with them and intervene with them. They were out the door and out of our kind of out of our grip in terms of being able to intervene with them. So we needed a way to intervene with kids earlier, more quickly, before they get into trouble because of the situation. And that's how we came to want to do this SBIRT program and start to screen students. So we started, we felt like we had to create some buy-in within the school system, and we did that with by starting at the top. We went to our school superintendent, presented our data, talked about just what we mentioned, losing kids before we had a chance to help them, and the idea that we really wanted to try this intervention, try this way of screening kids and being able to help them before it became a problem. And he agreed to that and spoke to our board and got board approval for us to try this intervention. And that's really how we launched within the school system. Kathy's going to talk a little bit about how we got some buy-in from teachers and kind of school level staff.
Well, this, back up just a little bit. The community, I think, was made aware through the Drug and Alcohol Coalition that Deb was part of, and I was part of too. And then there was also some information that was published in the Norwood Star, which is the community newspaper. But as far as the parents are aware of our screenings, height, weight, vision, hearing, all those things through the handbook. So it was more of a, they were made aware of it because it was listed as to what it was, and that we were going to do it at the same time as the scoliosis. And then they were able to have the passive consent, where if they did not want their students, their child, to be part of these screenings, any of them, they would have to just write a note and let us know that. As far as the teachers, they were made aware. We do health training every school year through public school work. So, and that includes the bloodborne pathogens and medication administration and things like that. So this was, there was a brief, I don't want to say a brief training program with SBIRT that they just had to read a little bit about it, what it was for, why we were doing it, and that it was going to be done in grades 6 through 9.
And Public School Works is a computer-based training program, so it was something that we didn't have everybody all in one room. They did it kind of at their own pace and read through the material and had to do a little quiz. Yes.
Then we are on to, as far as recording the information, when we do the screenings, all the screenings are recorded on a DAZZLE program, which is just a student data information program. So we needed to set up something so that we could record the information from for this year. So we did it through the DAZZLE program, and then we had to have a new field put in there so that we would be able to hold on to that information and collect the data. The scheduling of the screenings was a bit tricky because we had to coordinate with the health aides that I have in each building. I have 6 health aides in the building, and then I'm in one particular building. So we had to coordinate the screenings to go along with scoliosis, and we had to make sure that the teachers were on board, and then as far as having so many screeners set up so that we could cycle them through without too much of a backlog. And that has worked fairly well. Fairly well. We had some glitches here and there, but for the most part, it's worked very well.
So essentially, once kids are screened, when they're screened, they fall into one of three buckets. So there's 0, or no risk, low risk kind of thing. A 1 is that there's moderate risk and they require some brief intervention, and then 2 is they're referred to treatment. And so those services were either done by the person screening if it was brief intervention, or they were referred. They could have been referred for brief intervention or for treatment to our drug and alcohol therapists that we have in our building, which is our partnership with Talbert House. But then also in terms of planning, we had to plan for long-term sustainability. We had a grant to do this program through Interact for Health, which was a wonderful opportunity. It helped give us some seed money and time, the luxury of time to figure this out and plan for it. But then we needed to figure out how to do it on our own after the money was gone. And so part of what we did was, and you'll see in some upcoming slides, when we did training, we did not just train the people who were immediately involved with the program. We tried to train broadly so that many of the people in our organization, many of the social workers, the health aides, and different folks were trained so that this could be something that we could do on an ongoing basis, even when the money ran out. So just in terms of the training, we did motivational interviewing training and training on the SBIRT questions. We did a one-day workshop, and this is part of what we used our grant funding for. We trained our school nurse, our health aides, social workers, our health department nurse, Talbert House therapist, anybody who might potentially be involved. We had them participate in the training, and we did this through both didactic training and role playing. We spent a lot of time practicing our active listening skills, practicing doing the SBIRT questioning, practicing developing those informal, quick relationships with our partners so that we could be better at this questioning kind of piece. The training, we were really fortunate to have a consultant from the Ohio Department of Mental Health and Addiction Services provide this training for us, and that was a service that was actually free to us. And by providing that training, we were able to spend a lot of time learning about how to do this well. And then, like I said, we created sustainability with the program by just training a whole lot of people so that everybody had a taste of what was going on and how to do this. So the implementation phase of this, we already kind of mentioned. We screened all 6th through 9th graders, and if there was no problem, they did not mention that they used or had friends that used alcohol, we coded them 0, encouraged them to continue making good choices, and they were given a copy of a brochure called 20 Reasons. And this brochure was developed by we have a teen empowerment program here, which is a youth-led prevention program, and they created this brochure specifically for this SBIRT intervention with our kids. So it's kind of nice that our kids hear from our kids about not using alcohol.
And it was nice to be able to give them something to walk away with, to have in their hand, a couple more reasons and things to come back with if someone would try to encourage them to drink.
So if they mentioned that either, yes, they had used recently or they had friends that used, they might be screened as a 1 and referred for brief intervention with our therapist. And then if they said that, yes, they had used and the use was fairly recent or significant use, then they were referred, they were coded as a 2 and referred for treatment with our therapist or an outside agency. So these are our outcomes for our first year. We screened a total of 606 kids. 141 were 6th graders, and of those, all of those coded 0s. Now, I'll mention to you that our 6th graders were the very first kids that we screened. So we believe that that part of that, all of them being 0s, is not necessarily all of them truly being zeros, but that we were still learning how to be good screeners. So we suspect that this year that number will be up a little bit, just because we've gotten better, more skilled at doing the screenings. Our 7th and 8th graders, we screened 265. 2 of those screened in code 1 and were referred for brief intervention. And in our 9th graders, we screened 200. 26 of those were screened in code 1 for brief intervention. Of those kids, once they met with the therapist for some brief intervention, 9 were referred on to further treatment, and 2 were actually open for treatment services. So, like we said, it's a simple program, but we know that simple is not always easy. So these are some lessons that we've learned along the way.
One of them is just the coordination of it all, trying to figure out, trying to organize any kind of screening for kids, especially if you're just not polling 1 or 2 at a time. You have to figure out when the testing is, when are the specials, when is lunch, who comes in what time, and then just coordinating all of that with the therapist as well as the health aides and myself, and getting everybody. So that part was a little bit difficult. And then, again, we had some computer glitches for a little bit as far as who was able to enter the data, and it was then on paper and then going back and entering it. So all of that has been smoothed out just a little bit more. Having more than 1 screener is really optimal because how we've done it is we usually pull in like 5 or 6 kids at one time, and while I am actually doing the screening for scoliosis and we're documenting who's there, then a screener will be seeing 2 other ones, and we kind of rotate around. You have to find a place that you can speak to them confidentially. You don't want to have everybody out in the open, and that was a little bit difficult because we were losing kids in the hallway because they thought, oh, this is a good time to go play around. So we would lose a couple of kids that way. So trying to have a good tie on where the kids were and where they were supposed to go, and they would have a checkoff sheet, and all of that has been improved a little bit on this year since we started. One thing that I did notice, and Deb and I have talked about this many times, is the medical staff, myself, is not as comfortable with that type of interviewing as, say, social workers are. Medical people would say, what's your problem? How can I fix it? Whereas the social workers are more soft and fluffy and try to warm up to the kids a little bit first, and then see if they would open up a little bit more. So mine was more cut and dry, and the social workers are more soft and fluffy. So I think they would have gotten better responses than I would have.
We didn't do as well as we had hoped with the actual brief intervention portion of the project. Part of what we think happened is that we had some varying views. Even though we all received the same training, we had some varying views on what brief intervention might have meant and how that should be delivered. And so one thing that we've realized is we have to kind of do a regroup and delineate more clearly, again, what is brief intervention and who gets referred to that and who is responsible for doing that. So in that 26 kids that were referred for brief intervention, we did that a little bit differently than what the literature suggests you do in brief intervention. So we know that, and we know that we have to improve on that. We still had a process, and we still had 9 kids referred to treatment and then 2 that were open, which is positive. But it's one of those things that you had to do it, learn it, realize we didn't do it the right way, and now redo that and redo it the right way.
And I mentioned earlier about having the different spaces for entering the data into our computer program. And one thing we didn't think about last year was when we set it up, we only had 1 slot that was available to enter the data in. So we had to go back and have all of that redone this year so that we could enter the data. And then when we went to enter it, it didn't go in right. But all of that is smoothing out now. So a lot of things that we didn't think about up front, like I said, you learn as you go, and it's beginning to be much more smooth this year than it was last year.
And we worked with Prevention First, and they developed a toolkit to help other schools launch SBIRT. So that's just a resource for folks if you are interested in that kind of thing. So that's our experience in Norwood. We'd be happy to
answer any questions.
Yeah.
And just real quickly, this is Kathleen again, and in this slide you'll see some resources. So when you go on to the website, you'll be able to click on the links that are here. The Institute for Research, Education, and Training in Addictions provides a lot of good information, and they do webinars about every other week, and a lot of them recently have been focused on youth. And so I would highly recommend people get on that mailing list. Just go in and log in and get a password, and then you can get on their mailing list and start finding out about the various webinars that they're doing. The Practitioner's Guide, that website has the tool that is being used in Norwood. And there's also a lot of good information on the Massachusetts Bureau of Substance Abuse Services, because they've been doing this for a while. New York also, OASIS has their substance abuse agency has a lot of good information, and you can find out more about what's going on with SBIRT in Ohio at the Mental Health and Addictions Department's website. So, Alyssa, let me turn it back to you to solicit the questions.
Okay, so this is a time to put any questions that you have in the questions box that you may have thought of during the presentation. We have a couple already in the queue. Let's start with a question from Scott, and he asks, can you explain a little bit about the SBIRT tool itself and how it differs from other screening tools?
This is Deb, and SBIRT is a strategy. So there are many tools to do SBIRT. The actual process of screening, you can use several different screening tools. You can use something called the CRAFT. The one that we use is a very simple 3-question guide. We ask kids, do your friends drink alcohol? Do you drink alcohol? And if you do, how frequently and when was the last time you drank alcohol? But SBIRT in and of itself is a strategy. So you can use the CRAFT and be doing SBIRT, and then there's several others with lots of different names to them. We chose a very, very simple one.
Okay. Let's see, we've got another question. And it is, what did you include in your charting?
The charting was basically just the date of the screening, and then one of the 3 cues that Deb had, either 0, 1, or 2. And then they are the spaced comments, so that if they were, this year it's been much improved because of the people that are screening are putting more information as to what the child actually says and things like that. But this is basically just the date and the different cue as to whether they were referred or whether it was a brief intervention or whether there was no concern at all. So those are the numbers that we use.
Okay, but another question is, can you describe what a brief intervention looks like or sounds like?
Sure, and just to know that this is our tricky spot. This is what we're still working on and trying to do better with. But essentially, a brief intervention, if a student talks about that they have friends or siblings that use alcohol, or they report that at some point they've tried alcohol, or they've had it in the past, then the person who's doing the screening might talk to them about the effects of alcohol, might talk to them about brain development, that really a young person's brain isn't fully developed until 25, and that anytime somebody uses alcohol, it disrupts the growth of the brain in the right ways, and that's why that we encourage young people not to drink alcohol until they're older. So we try to do that kind of intervention with them, which is more fact-based and not preaching, not like, oh, you shouldn't do that, but those kinds of things. And then they might also work with them on things that they already identify, like if they're an athlete or they're involved with something that alcohol would impact them negatively, talking about how using alcohol would negatively impact those areas that they enjoy or they are involved with, as a way to kind of get them hooked on this idea that this is not a good thing. Now, again, this was our tricky area, and so in some cases they were simply written down as brief intervention, referred to the therapist, who then did the same kind of thing. My concern is it's probably not as impactful 2 days later to go talk to somebody else for 15 minutes as the person that you're sitting across the table from when you say, yeah, I drank some alcohol at my cousin's wedding. So that's an area that we're getting better at. But the brief intervention should be fact-based and connect somehow to the use, just in terms of giving them some information to help them make better choices about not using.
Great. Can you go over again what the 3 questions are and describe if they get at more than just alcohol use, including other substances and possibly depression?
Sure. And I think this is kind of what Kathy was talking about when we were talking about the ways that the screeners talk to kids and go a little bit further. You can ask just the 3 questions. Do you have friends that use alcohol? Have you ever used alcohol? And if so, when was the last time and how frequently? So those are the 3 questions. However, you can talk to kids, if somebody says, yes, my friends use alcohol, they use alcohol, then you might say, well, when do they use alcohol? And when did they tell you about that? Are you with them when they use alcohol? Do you ever get in the car with them? So it's really kind of up to the screener to expand that out in a way that's appropriate. But those are the 3 main questions. Those are the decision-making questions that you follow. But if the screener can kind of follow wherever the student goes with those, with what the information they're giving them, it's not really designed to screen for depression or for other substances, although I can tell you that we've had kids that have said, no, I don't have anybody that drinks alcohol, but my friends smoke marijuana. So we've noted that and looked at that. But we are simply asking about alcohol. We do get other information, but that's what we're asking about.
This is Kathy, one of the things that I'll go back to when I talked about the medical people versus the social worker people, just the way they question. I mean, I think they have a way of not really probing, but just tell me more about that, and why did you decide not to use, and why did you decide to have that drink, and things like that. And I think that opens them up and makes there's more of a trusting relationship. Plus, almost all of these people are within the school, so these kids will see them again and know that they're a trusting person, that's someone that they can go to. So all of those pieces together really, I think, enhance the program.
And if I can just share an anecdote, Kathleen kind of mentioned that anecdotally we know some things. We had a situation last year where a student came in and told us no, and we know that not all kids are being honest with us, and that's okay. But a kid told us, no, I don't use, I don't drink, I don't do anything. And then about 2 weeks later, went back to the person that screened him and said, hey, I just want to tell you, I wasn't completely honest with you. I do use alcohol, and I have a problem. I need help. And he came back to her because she had talked to him. She had done it in a way that he wasn't threatening and non-judgmental, and she was able to get him connected and move him on for services after that point. So we're also not of the opinion that just because a student doesn't tell us the truth, that it's not a good intervention or it's not a good exchange also.
It's worth the time just to know that it makes them aware that there's someone to go to if they feel that there is an issue, even if they're not going to tell you at that moment. They know that they can go to Deb, or they can go to Joanne, or they can go to Alan, and these people are in the buildings and they can let them know at another time. So it's just it kills more than one bird with a stone, I guess.
Okay, we've got another question that asks, who gets referred, and then who is ultimately responsible for the referral?
We were just kind of talking about this. So last year when we had this grant that kind of helped organize this, the students that get referred were in, like we said, the number 2 bucket, or in our case, they were in the number 1 bucket and then moved on to number 2. And because we had this grant, we had the person, we had a therapist, a drug and alcohol therapist with us from Talbot House, and they did get a little bit of money from the grant to kind of manage any of those kids, case manage or care manage those kids. So that's how that worked last year. This year, that's one of those things we have to figure out is how are we going to do that, because that money is not there for them to be care managed by that organization. And so I think that one of us are going to have to take on that responsibility of just double checking and making sure that if a child was referred, which we still have them in our organization and they can still be seen, but that person who oversees the whole process to make sure that things don't fall between the cracks, we have to redo that work in our own system and decide who's going to do that for us for this year.
About how much time does it take to do a screening?
It varies, actually. It can be very quick. I mean, if the scoliosis, it doesn't take very long at all. You just have to explain why you're doing it, and if they're 7th and 8th grade, they've done it before, so they are aware of that. And then they move through to this screening, and it's a matter of the questions and how those questions play out. So it doesn't.
It doesn't take long. First, we should say that we tied it to scoliosis screening because that's a screening that we do with kids in that age range anyway. So they were already being removed from class, so we weren't removing them one more time from class. And so a screening truly can be as simple as, you know, about 2 minutes, a minute to 2 minutes, to more involved to like a 10-minute kind of discussion, if that's what needs to happen. Which is why we found that having a couple of screeners was really a better situation, because if you did get a student that needed a little more time, it didn't stop up the line, because the scoliosis screenings go very quickly. And so really it can be a matter of a student comes in, you say, hi, how are you? I'm glad you're here today. You're not in trouble. I just want to ask you a few questions. Oh, are you a UK fan? I see that on your shirt, to build some rapport. And then we're going to ask you a few questions about using alcohol. You know, this information we're not going to share with the school, so you're not in trouble. Do you have friends that use alcohol? And they might say, no, I don't. And you say, okay, great. Have you ever used alcohol? No. Great. I'm so glad. What makes it so that you don't want to use alcohol? What happens in your life that you don't want to use alcohol? And then they may say, you know, I'm underage, I play sports, my parents would kill me, whatever that is. And we encourage them and send them on back to class, give them the brochure and send them back to class. So it can be very, very short.
Okay. Is the screening done orally, or is it a written survey?
It's orally. We just talk to them.
Okay. What literature or learning aids do you use? So you can go ahead and answer the last one.
For ourselves or for the students?
For the students.
So for the students, we give them, when they leave, we give them a kind of our brochure that is the 20 reasons not to use, that was written by kids. Just as a way to give them to, you know, some comeback, some things to say. Those are really the only literature pieces that we give them, outside of just the discussion, and that they can come and talk to us if they, you know, want to talk more about it.
Okay. Can SBIRT include screening questions that get to more than alcohol use, including like other substance use?
I think it can. I think part of that that's what you're going to have to kind of do some research with your school and your school district, and that's where all of the prep work comes in, because then it gets a little bit tricky in terms of what are you asking kids and what are you getting permission to ask kids, and it just gets a little bit tricky. Most people are okay with the idea that, you know, since alcohol is it's illegal for children under a certain age, and it's pretty cut and dry. Where other drugs, it just gets a little trickier, and and sometimes you start small. We started with alcohol because we felt like we had data from our student drug use survey to support this work, and that we felt like we could get the buy-in from both our community and our school to do it, and move forward there. I'm sure there are things out there. Maybe Kathleen can speak to that more. What specific tools are out there to do those screenings? But we just do alcohol and go from there.
Okay. Another question we have is, who pays for the intervention specialist, and is it a permanent position?
We are very fortunate in Norwood. We have a couple of things. We have a great partnership with Talbert House, and I would encourage any school district who's going to do this, do not try to do this on your own. Partner with a substance abuse organization that can help you. So students, we had a grant. So last year, prevention services, the brief intervention and kind of that care management piece was covered under the grant. This year, we were really fortunate that Talbert House has given us some of their county dollars for prevention that they get from the Mental Health Services Board and Addiction Services Board to provide somebody at our building to both help with SBIRT and to do some of the brief intervention. We have a drug and alcohol counselor. Her position is paid for as a fee for service, so either it's billed through Medicaid or private insurance. We still really struggle with kids who don't have either Medicaid or private insurance, but that's how right now that is paid for.
Okay. Can you talk about how you provided the space for privacy when kids were giving responses, and also the confidentiality piece of the responses that they give?
As far as the space that we use, we have six buildings, and we use 5 of those, and it was just a matter of mapping out what would be the best place to have the students come and talk. The last year was a little bit tricky with some of the 6th graders in one of our schools because there really was no place to go. We had to finagle towards the end of that process and get a different room and have them, like I said, that's why sometimes we lost them going down the hallway, because they'd go in for the screening for scoliosis and they were supposed to be checked off and go to the next room, and they wouldn't. So this year it's worked a little bit better, because in the high school and the middle school, the rooms are closer together, and there's actually there's doors that can close, and it's very private. So it just takes a little bit of mapping out what your building actually looks like and what's available. And I'm sorry, I forgot the other part of the question.
The other part was how you handle the confidentiality of the responses.
So this, as part of our planning, we had a lot of discussion about confidentiality and what would we share, what would we not share. And because we couched this as a screening and put it in with all of our other screenings, like vision, hearing, height, weight, scoliosis, all of those things, what we decided is that we would use the same principles for that as we would for our SBIRT as we would use for those, which means that if a child screened positive, we would talk to parents about that. Now you saw from our numbers we didn't have any little guys screened that way. The way that we did it with our middle school and high school kids was we offered them the option of that we would give them one day to talk to their parents, and then we would call and follow up. We could call with them, with them in the room with us and talk to them, or we could call them and talk to them. but somehow we needed to communicate with parents about what was happening with them and what was going on. It was confidential with the school. We did not go back down to the principals, assistant principals, anybody in the administrative offices and say, here's the list of kids that admitted using alcohol. There was nothing like that. We didn't share that information. But like I said, we did determine on the front end that since we put this together under the umbrella of screening, we had to treat it like any other screening. And we told kids ahead of time that, if you tell us your friends, we're not ratting out your friends. And, if there's information that we need to share with parents, we will. So we know that that's probably why we didn't get, a larger number of kids reporting that, yes, they use. But we did get a fair number.
Okay. Another question is, how do you explain, what you're going to do in the screening to the child right before you do it?
Well, when they come in, the screeners introduce themselves and tell them that they just have a couple of questions about alcohol use, and just what Deb got finished saying, that it's not going to be relayed to the school, and we're not going to tell your friends, and they just give them all of that information up front, and then a little bit of soft chatting, and then they ask the question. So the students know ahead of time what they're going to be asked about and the options of what will happen if they do disclose, and that we will not share with the school, and we won't go down the hallway and pull your friend out of gym class because you said that he was drinking last weekend.
But we also do say, just especially the younger the child. The younger the child, we make sure we say something. You were just here for scoliosis screening. This is one other type of screening. Just like when we check your ears or your eyes, one more thing we want to check on is we want to make sure you're well, and here's what we're going to ask you about this. So we do kind of say it's another screening that we're doing, and that we'll be asking you this each year.
Okay. Do you have any other drug or alcohol prevention-related programs in your school or classes?
Yes. We actually have quite a bit going on. We have a really active drug and alcohol coalition, which is actually part of where this launched from. But we do several things. We have 2 youth-led prevention programs. In the middle school, we have what's called Teen Empowerment, and that's a youth-led prevention program. In the high school, we have a group of youth that get together, and they're called the Positive Peer Influencing Team, and they do a lot of prevention services. And we have, much like many schools, we have people who come in and speak to kids. We do youth summits each year. Our kids are involved with regional youth summits. On our drug and alcohol coalition, we have a team that works specifically on youth activities and working toward making sure that there are youth activities in the community that are available. We do a lot of work with parents to try to encourage parents to talk with their kids about drugs and alcohol on the front end, because we know that when parents are involved by talking to their kids about substance use, they're less likely to use. So we try to weave it all together.
Okay. As far as the grade levels that you screened, you did up till what grade?
We did 6th through 9th grade.
And was there any reason for not screening above that?
Really, it was an issue of that those are the years that we do scoliosis screening. We actually do scoliosis from 5th grade to 9th grade, but we were concerned about doing the screening with 5th graders. We thought that might be too young. And our data shows us that our kids start to use around between that 6th grade and 7th grade year. And so we wanted to start screening by 6th grade so that we can start to have some information and some data and start to give them those positive reinforcements. Like I said, we wanted to couple it with a time that kids were already being pulled out of class. And so essentially that's why we chose 6th through 9th grade. We, again, we screened a lot of people. We screened all of our health aides. We screened the social worker in the high school and therapists and different folks that work with those older grades, with the idea that when kids come into the clinic for any reason, people were prepared enough they could ask those screening questions, even though it wasn't an official mass screening time. Those questions still could be asked when they come in because of a headache or because of needing a Band-Aid. They could still be asked in the higher grades. But that was our rationale for why.
Okay. Couple final questions. Can you talk more about your interaction with the parents and when they were notified of the screening, what they were told, and if there was any release that they had to sign?
That goes back to there was something put in the Norwood Star, which is the newspaper, and then the Drug and Alcohol Coalition that meets, they were made aware. The Board of Education was aware, and so then it was also put in our handbook along with all the other screenings. And the parents have to sign off that they've read the handbook. Whether or not they do, I don't know. But they are made aware of all of the screenings in the handbook. So they're made aware of it in that way. It's also on the front of my website that's connected to Norwood Schools. So they were made aware of it in a roundabout way, I guess, as far as a mass letter going out. We
did send a letter out when we first got the grant.
Okay, we did.
That said that this is the direction we were moving. We were going to do this, and we got nothing back. We got no information back, no pushback, no yay, good job, nothing from either way.
I forgot about that one.
Yeah.
Okay. We have a couple people asking about the 20 Reasons document, and if you're able to share that.
We are. In fact, we just couldn't figure out how to get it uploaded in color for the workshop. But I would be happy to send this PDF to anybody who I can send it to you, Alyssa, maybe. And,
okay.
You can.
Yeah, and then we can send it out in the follow-up email.
Sure. We are happy to share it, and our kids will be thrilled that other people would be interested in it.
Okay. And also the Prevention First toolkit for getting SBIRT started, is that something you can share too?
How
that
is
through Prevention First. So
yeah, there's actually, this is Kathleen, Amber Mayborg at the Prevention First responds to those requests, so we can put that information on our website near where we post the webinar itself, and so that people can rank a request.
The 20 Reasons is included in the toolkit.
Okay, great. Another question about if somebody wanted to get trained on how to perform an SBIRT screening in Central Ohio, is that something that's available?
We did our training through the Ohio Department of Mental Health Services, and I can get that information. I can't remember the lady's name who did that for us.
That's Ellen. This is Kathleen again. That's Ellen Augsburger. Ellen is the person at the SBIRT project for the state, and they also just hired a new trainer. They will do training of groups that want to start SBIRT. I don't know about an individual person getting the training. There are a few other projects in the state that have been funded recently. For example, the University of Cincinnati, in the School of Social Work, they now have a grant from SAMHSA to train social workers, physicians. These are all students like medical students, social work students, pharmacy students, and nursing students in Southwest Ohio. And there's a similar grant over at the Wright State area in Dayton, and another grant up in the northeast part of the state. I believe that's a Sisters of Charity grant. I don't know if they're doing any individual training, but I think any of those three could also be contacted, as well as Ellen. And we'll put that information out on our website.
Okay. Then finally, our last question, unless anybody chimes in the next 5 minutes, is they make the point that Ohio Ohio is the only state in the nation without health education curriculum mandated in the schools. So is anything that you're finding out a way to support an initiative to get a statewide mandate for health prevention, or is that something you're looking towards?
So I don't. This might be a more of a Kathleen question. I'm a proponent that that any prevention services that we can offer to kids is the best place to offer them information and education, because we have them here, and it's not hit or miss, and we can do it in a really systematic way, in a defined way. I know that there's some challenges with that, and I think it has to do with a lot with reproductive health, not so much the drug and alcohol kinds of work. But I think anytime that you can support, that we're doing these other kinds of things because kids don't have information, or because they don't know how not to say no, or they don't know what alcohol does to their bodies or their brains, I think any of that would support that kind of work.
And yeah, I mean, I think this is certainly something that we've struggled with in Ohio, and unfortunately we're moving in the wrong direction, because the state school board recently abandoned what was the former, I think they call it the 5 of 9 rule, and there were these extra, I don't know, they're not really extracurricular, but they are sort of quote-unquote non-academic items that schools were expected to do 5 out of 9, so they included things like health education, the school nurse, the physical education, et cetera, and now the schools have pretty much total discretion over whether they're going to do it or not do it. So that's a big problem in Ohio, and right now UHCAN Ohio is working with a number of our partners, and I've spoken to legislators about trying to take a more systematic approach to prevention in Ohio in the schools, because it is such a quilt, kind of a patchwork quilt, where some schools like Norwood schools have a very thoughtful, organized program, and other schools have very little. So there's a lot to be done.
Okay, well, that is all the questions we have for today, and we're just about at time, so that worked out nicely. We will be sending out a follow-up email tomorrow with some of the information you requested, links, people who you can contact for more information. But if you'd like to reach Kathleen, Deb, or Kathy, their emails are on the PowerPoint, and feel free to reach out to them with any questions. And look for our email. And I'd like to thank Kathleen, Deb, and Kathy for joining us today. Are there any final words you'd like to share with us before we leave?
Oh, thank you, and good luck.
Right. Thank you very much.
Yeah, and I would just like to say that this is really all part of a process. We are, working within, with the Department of Health, who does training for school nurses. We've been tabling at different gatherings of school nurses and other school personnel and health personnel. And so we're very, we, UHCAN Ohio, are very happy to respond to anyone who might be thinking about trying to introduce SBIRT into their school. We can help make the linkage with the Department of Mental Health and Addiction Services. I know we didn't touch on this at all today, but in some school districts have raised the issue of concern about lack of treatment resources if someone is found to be addicted and needing those resources. Here in Central Ohio, we're working with various groups to identify how those resources can be made available in a more expeditious way. So there's a lot that we can troubleshoot for any school that's thinking about undertaking SBIRT.
Great. Well, thank you for joining us this afternoon. Look for our follow-up email later tomorrow, and we hope you have a great afternoon. Thanks, everyone.
Thank you very much.
Thank you.